Hello, and welcome to Bite-Size MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organisations, and the material covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on drug-induced lupus under the section of rheumatology. So you will recall that the classification of lupus, which we have already discussed, the three of them for you are systemic lupus erythematosus, or SLE, which is what a lot of the times clinicians describe as lupus. Second category is subacute cutaneous lupus. Third is discoid lupus, and today's topic, which is going to be on drug-induced lupus. So what is drug-induced lupus? It is a quasi-lupus illness seen after exposure to certain medications, and it can happen from a few weeks after that exposure to up to more than a year. In terms of its epidemiology, it is more common in Caucasians, so that's quite a contrast with SLE and also cutaneous lupus, which are actually more common in non-Caucasians. Drug-induced lupus is also more common in older patients, especially above 50, which is again quite a contrast with your cases of SLE and also your subacute cutaneous lupus, which is actually quite common within the age of 30 to 40. It has an equal prevalence amongst men and women, and it is really quite uncommon in children. As for its clinical features, it's really quite a heterogeneous disease. It can actually be so severe that it could mimic a picture of SLE. And that is to say that you may see arthralgia, arthritis, myalgia, cervicitis, hepatomegaly, and an erythematous papular rash on the case of drug-induced lupus. However, other systemic manifestations that you would expect in a case of true SLE, such as CNS manifestations like seizures and deliriums, are really quite rare in a case of drug-induced lupus. Now, probably the most important thing for you guys to know in this section for your MRCP exam is the actual associated drugs with these conditions. It is a list, and I'm afraid there isn't any mnemonics on this to thoroughly cover all of this, and this is just something that you will need to put it into memory by repetition. The drugs that are frequently associated with cases of drug-induced lupus are minocycline, hydralazine, procainamide, isoniazid, quinidine, metildopa, sulfasalazine, chlorpromazine, and anti-TNF alpha drugs. So, in terms of the investigations in a case of possible drug-induced lupus, really the biggest thing is your history, because it's a detailed history of what the patient is currently on or was recently on or previously on and is now discontinued that could potentially hint you towards a diagnosis of drug-induced lupus. It would be appropriate to run the tests as you would do for a possible case of SLE, because remember, this is an SLE mimic, so it's very important for you to make sure that this is actually not a case of systemic lupus erythematosus. So you would be asking for all of the immunological and also histological investigation that will be aiding you to make that diagnosis. We have covered thoroughly all the investigations that are needed in order to make a diagnosis of systemic lupus erythematosus, and please feel free to have a look at that video in our video sections to have a better understanding or for it to be a refresher of your knowledge. Importantly, with drug-induced lupus, cases of anti-dsDNA and also low complement levels are really quite rare. And your ANA or anti-nuclear antibody are generally positive in the majority of cases, and that's about 75%. Another very classic MRCP question would be the specific antibody that are frequently tested in a suspected case of drug-induced lupus, and that test is called antihistone antibodies. So it's really important for you to realize that antihistone antibodies can actually be positive in about 80% of cases of actual systemic lupus erythematosus. However, it's also positive in 95% of patients with drug-induced lupus secondary to medications such as procainamide or hydralazine. So it's really quite a sensitive test. In terms of management of drug-induced lupus, obviously the first thing would be to removing the offending agent, and you could also use adjunct medications such as NSAIDs to help with control of pain or arthralgia. Sometimes, if there is more evidence of systemic involvement, such as serositis, you could consider a short course of corticosteroid to help with that. Usually the prognosis is actually really good in this condition after removing the offending agent. So now let's do some questions. A 60-year-old male presents to his GP with worsening fatigue and arthralgia. He has a history of difficult to treat hypertension and has tried multiple drugs. In the last few months, he has recently started a new drug for his hypertension. The GP suspects a diagnosis of drug-induced lupus. Which drug is most likely to be the causative agent? So your options are A, doxazosin, B, nifedipine, C, bisoprolol, D, hydralazine, E, spironolactone. And if you recall correctly from our discussions earlier, you will realize that option D, or hydralazine, is the most classically associated drug with drug-induced lupus. It's really important to mention that some of the other drugs that are mentioned in the vignette have been associated with the cases of drug-induced lupus, and there are case reports on these. However, for the purpose of MRCP, if you have one of the drugs that I mentioned on the list originally as one of your options, I strongly encourage you to go with that option because those are the classic associated drugs with drug-induced lupus. Question 2, which antibody is most specific to drug-induced lupus? And the options are A, ANA, B, anti-dsDNA, C, rheumatoid factor, D, anti-URMP, E, antihistone. So you will remember from our talk earlier that the most specific antibody to drug-induced lupus is antihistone antibody. The remaining of the antibodies you really should be completely familiar with them. ANA is the most sensitive antibody for the cases of SLE, and you need to have a positive ANA in order to be considered to have systemic lupus erythematosus. Anti-dsDNA is one of the most specific antibodies in the cases of SLE. And that, if you recall correctly from our lupus lecture, it goes hand in hand with antiphospholipid as well as anti-Smith antibodies. Rheumatoid factor is one of the antibodies that we look at in cases of rheumatoid arthritis, but it can be elevated in many other conditions. And anti-URMP is a very specific antibody in cases of mixed connective tissue disease that, again, you need to be familiar with for the purpose of MRCP. Thanks for listening for this episode of Bite-Size MRCP. If you liked what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure that you don't miss our next episode. Let us know in the comments which topics you would like to hear in the future. See you in our next episode.